Hello, thank you for joining today's NCCN webinar for patients advanced and metastatic bladder cancer. NCCN stands for National Comprehensive Cancer Network. NCCN is a not-for-profit alliance of 33 leading cancer centers across the United States devoted to patient care, research, and education. NCCN Foundation is a nonprofit organization that raises funds for the NCCN patient resources, including new and updated patient guidelines, as well as patient webinars. These are funded using financial support from generous donors. The NCCN guidelines for patients are based on the NCCN clinical practice guidelines used by healthcare providers worldwide. They explain the same options for cancer care, but are written for patients and their caregivers, family, and friends. You can view and download free copies of the guidelines for patients from the NCCN website. High quality printed copies of the book can be purchased through Amazon. The NCCN webinars for patients complement the NCCN guidelines for patients. They cover a series of topics discussed by expert presenters. Viewers have an opportunity to ask questions at the end of the presentation. This brings us to the presenters for today's webinar. I'm very pleased to introduce Dr. Philippe Spies. Dr. Spies is Assistant Chief of Surgical Services at Moffitt Cancer Center. Following Dr. Spies, we will hear from Dr. Jean Hoffman-Sensitz. Dr. Sensitz is Associate Professor of Oncology and Urology at the Sidney Kimmel Comprehensive Cancer Center at Johns Hopkins. Our third presenter today is Rick Bangs, patient advocate from Bladder Cancer Advocacy Network. Now I will turn it over to Dr. Spies.
Thanks so much, Tanya. First of all, I'd like to thank the NCCN for organizing, I think, a really important, exciting webinar on a topic which is very timely. Bladder cancer, the care is evolving very quickly. We clearly see that we want to make sure we get the most up-to-date information to patients and families around the globe. So I applaud all of you for joining us today, and it's a privilege to be joining you with my esteemed colleagues. My name is Phil Spies. By all means, please call me Phil. I'm a urologic oncologist at the Moffitt Cancer Center in Tampa. Been here for about 17 years. My day-to-day practice involves the care of a lot of patients with GU cancers, including bladder, kidney, and other cancers. I do serve as the vice chair of the NCCN Bladder and Penile Cancer Panel, and I'm also privileged to be on the NCCN Board of Directors and Steering Committee. This is my contact information. By all means, if anyone wanted to ask me a question, either as part of this or beyond, please feel free to reach out to me anytime. So, I always like to highlight that the NCCN does a really incredible job, always providing the best level evidence in a very real-time fashion. And I think it's becoming increasingly difficult because very, very exciting for patients is there's exciting clinical trials taking place continually in all aspects in the continuum of how we care for patients with cancer, including bladder cancer. So these are continually needing to be updated, and I think there's a commitment from the NCCN and from all its panel members to make sure that we are offering the best level evidence and most up-to-date information to patients. So let's take a little bit of a deeper dive discussing epidemiology, signs and symptoms, and risk factors. I think that is really a critical topic for patients, for families, for anybody in the community who is maybe having some of these symptoms and is trying to ask themselves, what should I be doing or what should I be looking for? So first and foremost, I don't have any disclosures, financial ones. I do, as I mentioned, serve on several roles, leadership roles within NCCN panel on the bladder cancer and within the NCCN Board of Directors. And first and foremost, I always like to highlight that bladder cancer is a type of cancer that the lining is very contiguous with what you find in the ureter, as you see here, and kidney. So we refer to the cells lining the inside of the kidney, the ureter, and the bladder as urothelial cells. So oftentimes when we talk about bladder cancer, you may hear the term urothelial carcinoma, which is basically a cancer of the lining. And obviously when that involves the bladder, we call it bladder cancer or bladder urothelial carcinoma. Is the most common type of such cancers. So in terms of incidence, it is clearly something which we see a lot in day-to-day practice, is that bladder cancer is a very frequent cancer. It represents the 6th most common malignancy we see in the United States, 10th across the globe. And we see overall in the United States back in 2019, about close to 80,000, over 80,000 patients diagnosed with this disease. And unfortunately, 17,600 patients died of that disease that same year. We know the risk factors for bladder cancer, which we'll be discussing a little bit more in detail, but the major one is smoking and occupational exposure. We do know as well that the peak incidence of bladder cancer is usually in the late 60s to early 70s. It is 4 times more common in men than it is in women, and as we'll see in a few minutes when I show you the incidence and mortality rates. And as I mentioned, tobacco smoking is representing and constitutes about 50 to up to 65% of cases, occupational exposure and toxin exposure up to 20%. It is also important to understand that when we talk about bladder cancer, which we'll talk about in a few minutes, we really break down the disease into 2 different subtypes when we're talking about local disease, meaning cancer that hasn't spread to other places. We talk either of non-muscle invasive disease and muscle invasive disease. The distinguishing feature there is that once the muscle is involved, the treatment paradigm and how we treat patients is very different. We talk about more aggressive treatment because the risk that this cancer is going to progress is dramatically higher. And as I sort of indicated here, 25 to 30% of patients with bladder cancer present at first time with muscle invasive disease. And obviously that's something which, from an epidemiologic standpoint, we'd like to try to hopefully identify many of these patients before they get to this stage of the disease where the muscle's involved, so that we can potentially cure them in addition to not necessarily having to do aggressive treatment, which could potentially be very morbid and affect their quality of life. So this is back for 2024, the incidences. I hope all of you can see that. But when you look at bladder cancer in males and females, you see that bladder cancer is a very frequent cancer, represents, in fact, the 4th most common cancer in males, with over 63,000 cases, representing 6% of cancers. In females, it doesn't even meet the top 10. And similarly, for mortality rates in males, it is a very frequent cancer as well, is situated at number 8. With 4% of all cancer-related deaths represented by bladder cancer. And same thing for within females, does not hit the most frequent subtypes within the first 10 types or 10 prevalent cancers. So now for staging. Now, take a step back and say, what is staging of a cancer? Staging is essentially how extensive is the cancer? How deep does the cancer go? How aggressive is it? How aggressive do we need to be when we treat it? That is often an important question that physicians, when they're discussing this with the patients, are trying to determine how aggressive, how extensive is your disease, so we can sort of tailor and offer you not only the most curative treatment, but one that hopefully will not be as morbid. So we're going to sort of go down the scale and show that when we talk about staging, and this is clinical staging, if it's superficial cancer and it does not go into the muscle wall, that is typically T1 or less, there is a entity called carcinoma in situ. These are typically high-grade cancers that are confined to the superficial layer. But we know those cancers can behave more aggressively. Once the superficial layer, just before the muscle's involved, we call this T1, or what's called subepithelial connective tissue. Once the muscle's involved, that goes on to T2. And then if it goes beyond, as you can see in this diagram, once the muscle's involved, this is a T2. Once it goes beyond the muscle into potentially the fat around the bladder, it goes to a T3. And then if adjacent organs like the prostate, for example, is involved, it ends up being a T4. We define locally advanced cancers, because sometimes that is a term that we use, as T3 and T4 tumors. And then lymph nodes. Lymph nodes are the most common cancer or site that these cancers can progress beyond the bladder itself. And really the way we stage nodes is how big are the nodes, how extensive are the nodes. Is it a single lymph node? Is it less than 2 centimeters? That would be an N1. And if it's greater than that size, or there's multiple lymph nodes, it ends up being an N2. If you have distant sites, meaning sites like the lungs or the liver, then it becomes metastatic, and we call that an M1 disease. And then why that's really clinically relevant is because we know as patients have advanced stage, we know the survival rates, unfortunately, goes down dramatically. And that is when we need to be much more aggressive with our treatments to try to hopefully offer curative treatment for patients. Now, we're going to spend a lot of time discussing this, but obviously for every single patient, we need to personalize how we treat them. We need to take not only cure, but ultimately the goals of the treatment, what's important to the patient from a quality of life standpoint, from a societal standpoint, lifestyle, all those things are critical considerations. I would say, as we're going to be discussing, there is not necessarily a one right treatment for every single patient. And it's important that as a physician, as a patient, family, and as advocates, we really make sure we emphasize that. So what are the most common symptoms? And this is something I see in my practice fairly regularly, is sometimes patients will have blood in the urine and they may see a physician who may be very good, but they sort of dismiss it and they say, don't worry about it. Blood in the urine is normal. It is never normal to have blood in your urine. It needs to be evaluated, and that is automatically a reason to be referred to a urologist to be assessed. There is standard tests, which we're going to discuss, that should be done. Blood in the urine is the most frequent thing we see in over 90%. If you don't physically see the blood, that's a little bit different. But once you physically see blood, that is something which may not be cancer related, but it definitely needs to be ruled out. Frequent urination, feeling that you need to go to the bathroom frequently, which is actually a fairly common thing we see in men. That could be a symptom as well of more concerning symptoms and signs of bladder cancer. Burning with urination, things like back pain, which sometimes is a sign that there could be a blockage on the ureters or some compression of some organs. And feeling that you're unable to urinate is also a symptom. But I would say blood in the urine, like I said, is definitely by far the most frequent symptom. What are the risk factors? We talked about this. Tobacco smoking may not be necessarily you smoking. It could be secondary smoking, either from relatives throughout your life. And clearly, the more that you're exposed over a longer period of time, the greater the risk that you could develop bladder cancer. Age is a strong factor. We mentioned that males are much more at risk of developing bladder cancer. Race, chemical exposure, paint, and dye are frequently the ones we talk about. Chronic bladder problems, cyclophosphamide, which is a specific chemo agent that's used. History in some countries, like in parts of the Middle East, bacteria called schistosomiasis and arsenic exposure. Those are all things that we sort of should be asking our patients, and important for patients to know are risk factors for bladder cancer. In terms of what's done, once a patient is identified to potentially at risk, such as if you're having blood in urine, patients will typically should be referred to a urologist. As urologists, we do a set of tests. Typically, we will do some form of testing, and typically a CT or an MRI to assess the kidneys, the ureters, and the bladder. We will test the urine to see if there's abnormal cells or if there's signs of infection, if someone has symptoms. And the most important thing for bladder cancer is having a cystoscopy. Now, cystoscopy is basically when we look inside. Now, I have a lot of patients, which is, I definitely understand it. When you come to the office and you're saying someone's going to be putting a scope in my urethra, this is something that which is going to be painful. I would say today, these are procedures we do very frequently in the office, typically should be done with lidocaine to numb the area. It should be very tolerable, should not be painful by any means, and is a very diagnostic test. Bladder cancers, for the most part, have a very classic appearance, which I'll show you in a few minutes. So this is what a bladder cancer, what we call a papillary bladder cancer, will look like. And this is what is called white light or conventional cystoscopy, which is what we've done for many, many years in urology, which is we use normal white wavelength light to look inside. And these tumors, you can see, have multiple little polyp type appearances. And this is what the lining of the bladder looks like. And this is a typical, I would say, multiple tumors or multi-papillary tumors that you're seeing in the bladder. There is an exciting new technology, which we've been doing now for over 10 years, called blue light cystoscopy. Blue light cystoscopy is essentially a way of looking at the bladder, not only with conventional, what we call white light, but we use David wavelengths, and we actually inject a specific compound in the bladder to help us see the bladder a little more accurately. And sometimes as a urologist, you would say this is just a red area, could be inflammation. But sometimes what you see with blue light cystoscopy is you can see these fluorescent type areas, which are can be highly suspicious for cancer. And so it helps you detect and look at the bladder in a much more sensitive way, particularly in patients who have red bladders, where it can be very challenging to determine ultimately what is just inflammation versus what is potentially a cancer. So for local surgical treatment, I always tell patients it is important when you're seeing a physician that you feel that they're listening to your concerns and that they explain to you essentially what's going to be done. I always say that the relationship between a patient and a physician is one where it should be bidirectional. They should be able to give you the information about what they're planning to do. You should be able to ask the questions about what the risks, what the benefits, what could be expected, so that when you leave the office, you have a better appreciation of ultimately what's going to be done. It's also a very important point, which I'm sure we'll emphasize, is often very important to bring a family member with you. When you go to a doctor's office and they're giving you all this information, particularly when we say the word cancer, I would say that it can be very concerning. And obviously, sometimes having a second voice listening to you will help you really try to determine and give you a lot of the information that was discussed. So when we look and we actually proceed in removing a bladder tumor, which is actually a diagnostic and potentially therapeutic treatment, meaning we potentially, by removing the tumor, maybe in fact curing the tumor. But the only way we're going to determine the stage of a cancer is to physically remove it. So we use these instruments while patients are typically under general anesthesia. Oftentimes, we do paralyze the patient during the procedure for a very short period because it's important sometimes, depending on where the tumors are located, that we're able to do a very extensive resection, resect all the tumor, and are able to sort of resect it in its completeness. Now, paralysis doesn't mean that you're going to have paralysis after the procedure. It just basically means that during the course of the treatment, we're able to make sure the bladder you don't have any abnormal reflexes, which could impact and cause complications of some of these procedures. So something to ask about as well to your physician when they're doing these procedures, depending where the tumors, are they planning to do paralysis for the period of the procedure? What are the side effects? Most of the time there isn't, but those are all critical, I think, discussion points with your physician and your doctors. So once we resect the tumor, we know much more about what we're dealing with in terms of the stage, the type of bladder cancer, the extent, and the grade. Sometimes for tumors that are non-invasive, your physician may talk to you about doing what's called intravesical therapy. That basically means, as we sort of show here, is we put a catheter and we typically inject a medication in the bladder. That could be done right after the procedure, or that could be done a period afterwards after we have the pathology. We decide that based on the stage of the tumor, the grade of the tumor, the size of the tumor, and when it occurs. And as it is in the NCCN guidelines, we basically are able to offer the most effective treatment with the lowest toxicity and really escalate the treatment as we need to when we treat patients. Now, when someone has muscle invasive disease, like we said, when the tumor has gone into the muscle wall, we talk about doing oftentimes radical surgery. So in the males, that is called a radical cystoprostatectomy. As you see it in the top, we encircled the bladder and the prostate is removed typically together. People often ask me, well, why are you taking my prostate out if you're taking out my bladder? Oftentimes the bladder and prostate, as you see in this diagram, are together. Oftentimes the prostate in itself does not actually serve a functional purpose. And by removing it, sometimes you're able to remove cancer, which we may not have actually picked up. It may in fact be present in the prostate, but also it allows to make sure you get all of the cancer out. That is the typical operation when we do a cystectomy in the male, is to do a cystoprostatectomy, so removal of both those organs. And an important discussion point with physicians and the patients is this is a major surgery. We could probably spend a whole webinar about cystectomy and what the implications are for patients. But it's important when you are if someone gets to that point, that is a consideration. That is a very engaged conversation with the physician and with the family and the patient, because there's a lot of consequences to these surgeries in terms of the recovery, in terms of the long-term side effects, quality of life impact, what you can expect. It's really important that you feel all your questions are answered. I definitely feel sometimes talking to patients who've actually had these surgeries with the various forms of urinary diversion, which we'll talk about, is critically important. And what I have here are these nerves, the nerves that run on the prostate. Why is those important? Is the nerves that run on the prostate at the base of the bladder are actually the ones that are responsible for erections. So sometimes doing the surgery can have a dramatic impact on erections in males. And so it's important to have an appreciation that could be one of the side effects and consequences of the surgery. And sometimes we can treat patients to improve those afterwards with medications or various ways of devices and things. But that could definitely be something which could be a side effect of the surgery itself. Now, in females, also in recent years, we've moved to doing organ-sparing cystectomy. Many years ago, most women that had cystectomy had removal of essentially most of their female organs. The uterus, the ovaries, part of the vagina would be resected together with the bladder, because many years ago, we used to think that you had to remove all those organs to get all the cancer out. And now today we've evolved to often doing what's called organ-sparing cystectomy, removing only the bladder and the urethra in patients where the tumor has not extended into the uterus or adjacent organs. I always tell patients, everything can definitely be planned accordingly with surgery, but obviously at the time of surgery, it's important for the physician and the surgeon operating on you to tailor what they're going to do depending on what the extent of the cancer can be in the operating room. Sometimes you may see that there may be extension of the tumor into, for example, the uterus or the vagina, and obviously you want to make sure all the cancer is removed. But this is definitely something that can be offered to many patients, and that from a quality of life standpoint, from a decreasing the risk of having what's called prolapse, where you can have some of the female organs that could descend, it is critically can have a much more beneficial effect on the patients. When we do the cystectomy operation, we often remove lymph nodes as well. When we remove the lymph nodes, we're removing lymph nodes in the pelvis, essentially. That serves two purposes. We want to make sure we remove the nodes to know if the lymph nodes are involved. In about 30% of these patients, or in patients, we can identify there may be a small amount of cancer that's actually involved in the lymph nodes. And sometimes it also allows us, if there's only a microscopic amount of lymph nodes involved, that potentially could be curative. So that's a critical consideration and something that should be done at the time of surgery. And last but certainly not least, these are some of the outcomes that can be expected after cystectomy. So obviously, surgery can be curative in many patients, but also the outcomes that patients will have will ultimately determine by what the extent of the cancer is at the time of the operation. So as you see, as you have locally advanced tumor, the survival rates at 5 years can go down from 50 to about 40%. And that's obviously when it's important to see Jeannie and other medical oncologists to help tailor it and consider additional treatments for patients. This is some of the data. This is from a paper we published with colleagues a couple of years ago, giving neoadjuvant chemotherapy. So when patients have muscle invasive disease, like we discussed, oftentimes the multidisciplinary team will talk about giving chemotherapy before surgery. Why do we do that? There's now a good body of literature to show when we do that, we're in fact able to improve the survival rate for patients. And depending on what chemotherapy you get, you can see sometimes you can completely remove or eradicate all the cancer. That's what a complete response is considered. That can be up to 40%, anywhere from 20 to 40%. And you also have what's called downstaging, when you can have significant decrease from the stage from a muscle invasive disease to potentially cancer, which is now regressed and is much smaller and a lot less aggressive in how deep it involves and it extended. Now, the third part of the operation when you do a cystectomy, which is very important for the physician and the patient, and I would say even the entire team to spend some time discussing is how is the urine going to be diverted? As we all know, the bladder's function is to hold and store urine. Once the bladder is removed, the urine needs to be diverted somewhere. This is what's called an ileal conduit urinary diversion. This schematic diagram shows you that we use a segment of the bowel. We bring it to the skin as what's called a stoma, and then the patient applies a bag on there. That bag will need to be drained a couple times a day. Obviously, from a cosmesis standpoint, that could be very, very significant for patients, and it takes a long time to get used to it. It's important, again, to speak to patients if you're going to have the surgery and you're thinking this is an option, to speak to patients who are doing this, who've had this type of diversion, to understand what it means to be changing the bags, often practice doing so that you feel fairly comfortable going to the surgery, understanding what the consequences are going to be. Some patients, many can be a candidate for what's called a neobladder. A neobladder is basically when we create a new bladder out of bowel. And I always like to emphasize it works essentially like a bladder in the sense that it stores urine and it drains, but oftentimes patients have to catheterize themselves to get the urine out. And to actually urinate, you have to actually relax a different set of muscles. So you have to essentially relearn how to urinate. The recovery with a neobladder typically is a little bit longer than it would be, for example, with an ileal conduit, but in many motivated patients, this can definitely have a very favorable effect on quality of life. Last but certainly not least, the third thing is to do a pouch on the inside called a condon cutaneous diversion, and it comes to the skin as a small little opening, which is catheterized by the patients. So it's not really a ileal conduit like I showed you in the first one. It's a small little opening. You have to catheterize yourself versus having a bag on the outside. That also could be a good option for many patients who really don't like the idea of having an actual physical bag. At the same time, may not necessarily be candidates for a neobladder with the consequence of having to catheterize their urethra, for example. And, I think one of the most important points I like to always emphasize is this takes a multidisciplinary approach to every single patient. So as we're discussing, is every patient has different beliefs, have different important points that they sort of think is critical to their quality of life. And I think it's important when we take care of patients that we approach it in a way that is multidisciplinary from all our specialties. And I'm glad, Jeannie and Rick are here so we can sort of share how the multidisciplinary team can care for patients. And on that note, I will pass it on to Jeannie to talk about systemic and advanced disease.
Bill, thanks so much. That was great, great introduction and explanation about the disease that we both treat. I echo your comments and your sentiments about the importance of the NCCN, both from a provider perspective, and really having that as our Bible, and as a patient perspective, to have access to those patient resources. Just as a little introduction, so I'm a medical oncologist, and what that means is I'm an internist by training, then with additional training in medical oncology. So all medical oncologists specialize in the treatment of cancers with intravenous therapies that include chemotherapy, immunotherapy, targeted therapies, and what have you. At academic centers like Johns Hopkins, we really super specialize. So in my practice, I treat only patients with urothelial cancer. So that's cancers in the bladder or in the ureter and the renal pelvis. And in particular, because a medical oncologist is the most useful in those that have muscle invasive cancers that Dr. Spicer or Phil talked to you about, or advanced cancers, those are the patients that I actually see in practice. And absolutely, this is a multidisciplinary relationship that we have. 99% of our referrals are coming from the urology teams, either here at Hopkins, in the community, or across the country because of the trials that we do. And so we're really interfacing with those surgical teams as well as radiation and other subspecialties very often. So some of the themes I'm going to talk about are ones that Phil has already introduced, but I'll talk a little bit about systemic therapy first in the neoadjuvant or in the preoperative setting. And again, this is prior to this planned cystoprostatectomy or radical cystectomy in women. And in the guidelines, you'll find this here for patients with at least stage 2 or muscle invasive bladder cancer. Those are the patients are being referred from, Phil and other colleagues when that diagnosis is made after a TURBT. They're being referred to medical oncologists for consideration of this preoperative chemotherapy. And the reason for this, and Phil, you alluded to this earlier, is because there have now been several studies that show in those patients who are fit and eligible to receive preoperative chemotherapy, and that's not everybody because this is a fairly toxic therapy. These patients have to have a good, what we call performance status or fitness level, be able to be up and about, get yourself washed and dressed out of the house every day, able to go up and down flights of steps. We want to be sure patients don't have significant hearing challenges at baseline or peripheral neuropathy. And probably most importantly is what's the kidney function. Cisplatin is a drug that's both metabolized by the kidneys and then potentially toxic to the kidneys. So there's a level at which it's unsafe to give that medication. But it's this drug called cisplatin that has the most data for us to give prior to surgery for a muscle invasive bladder cancer or for selected patients that have lymph node positive disease. There have been a few studies that have shown that cisplatin followed by surgery is better than surgery alone when it comes to improvement in overall survival. This is one of them. This was published quite some time ago, back in 2003, but importantly shows that there is actually an overall survival benefit to the addition of that chemotherapy. And we show this in the setting of what's called a Kaplan-Meier curve. And this is important to kind of see that based on whether it was age or the stage of the tumor, just a muscle invasive tumor or more advanced, that these patients were still having a benefit of having that chemotherapy prior to surgery. Now, that study was published back in the early 2000s. There's been a more recent study that was done comparing two different modern regimens. So that's standard cisplatin and gemcitabine that we see a lot, or another regimen, which is a 4-drug regimen all given on one day called accelerated MVAC or dose-dense MVAC. It's really looking at outcomes of either one of these regimens, which a lot of us will give in the outpatient setting. And I think this study showed that both of those regimens were active. MVAC was probably a bit more active, but importantly showed that in the darker colors, the dark blue in the patients who had cisplatin and gemcitabine, and the dark orange in those that had MVAC, that the tolerance, so getting full dose in the darker colors versus not being able to complete all the prescribed cycles in the lighter colors, that patients were able to tolerate chemotherapy better in their preoperative setting versus in the postoperative setting. And this really speaks in part to kind of why we do things in this order. So as Phil mentioned, this is a really big surgery. There's complications and issues that can happen afterwards. And so for a few different reasons, we give the chemotherapy prior to surgery. So one, every clinical trial that we've done in the pre-op setting versus those in the postoperative setting is really where that benefit is seen. So if we try and do the same clinical trial in the post-op setting with cisplatin-based chemotherapy, our outcomes are not as good, probably because patients can't tolerate the treatment as well. That's number one. Number two is if I give a chemotherapy in the preoperative setting, send the patient back to Phil, they have surgery, and then we meet again together and talk about the pathology. Again, those patients have a complete response where the tumor is sensitive to that chemotherapy. Those patients are likely to do better long-term. But if the biology of the tumor tells us that it's not sensitive to that chemotherapy, we're still seeing invasive tumor or lymph nodes that are positive at the time of surgery, well, we worry that that's a patient where their outcome is not expected to be as good. And so our postoperative care is going to be different. So for those reasons, we continue to make this our standard of care. To give preoperative cisplatin-based chemotherapy in those patients who are fit and eligible. Of course, trials are ongoing to think about what else we can do in the pre-op setting, but as of today, this is continues to be the standard of care. So as Phil told you, that urothelial cancer is not just in the kidney, and involves the renal pelvis as well as the ureters as well. And importantly, for those patients that have upper tract urothelial cancer, not so common when it comes to patients who are first presenting into the office, but a little bit more common for those with later stage urothelial cancer, that there is data, not as much, but certainly data to give the same preoperative cisplatin-based chemotherapy prior to surgery. And we're seeing similar kind of outcomes in terms of these Kaplan-Meier curves, that if the biology of the tumor tells us that this is a tumor sensitive to that treatment, meaning they've had a complete response here in green, that they tend to do better than those where the tumor does not seem to respond all to the chemotherapy that we find at the time of surgery. So what about adjuvant or postoperative therapy? So certainly if there's a patient that comes to our office that has urothelial cancer that's maybe moved or metastasized into lymph nodes, and for whatever reason they were not offered or were referred for a preoperative chemotherapy, and there's multiple reasons why that might be the case, then we would think about offering chemotherapy in the postoperative setting. So that's always something that we think about. So in terms of thinking about what that looks like, so when Phil and colleagues will do these surgeries, especially for a bladder cancer, they'll remove the bladder as well as lymph nodes. So lymph nodes are normally throughout our entire body. You know, we expect to find them, but as part of the surgery, there is an extensive lymph node dissection that goes along with that. So if any of those lymph nodes have a tumor that's moved from the bladder into lymph nodes, or from the upper tract into these lymph nodes, that makes us concerned that this tumor has a high risk of coming back. So that's an important part of both the diagnosis as well as kind of the therapy for cancer, is to do the resection plus what we call that lymph node dissection. So this is kind of the second part of the story of treating someone in the what we call the perioperative setting. We've met them, we've offered preoperative chemotherapy, they've had their surgery, and now we're coming back and talking about, you know, does this patient qualify for postoperative or adjuvant therapy? So this is a trial that was published back in 2021, really answering a question for those patients that maybe had preoperative chemotherapy and then still had tumor that lived through that treatment that we find at the time of surgery. Is there something else that we can do? So a drug called nivolumab, which is FDA approved for several different indications, including advanced urothelial cancer. That drug was tested for a year in the postoperative setting for either patients who had had pre-op chemo and the cancer still lived through that chemotherapy, was invasive or in lymph nodes, or for patients maybe who had poor kidney function or other reasons why cisplatin was felt to be unsafe for them. So that was the population that was offered this therapy versus standard of care at the time, observation. So everybody on the study was followed in the postoperative setting, lab scan, physician's visits. And this was a positive study. So in the patients that were treated with the nivolumab, that's in the green, versus a placebo in the blue, the primary endpoint of the study was looking at disease-free survival. And so that was the time for the cancer essentially to come back. And so this study met what's called its primary endpoint. And so this is a standard option that we can talk to patients about in clinic for those with those high-risk cancers where we have great concern about the cancer coming back. So what about systemic therapy that we give for recurrent and metastatic urothelial cancer, meaning tumors where someone may have had that preoperative chemotherapy, had their surgery, and they were being observed, or for patients where their first diagnosis was with pain and with bleeding and scans showed metastatic disease? How do we think about that group of patients? So a lot has changed in the last couple of years, and a lot is changing this year. Things used to be easy, but easy wasn't always as good for patients. So back in as early as really the spring of 2016, this was our roadmap, which was for patients who were ineligible to receive any chemotherapy because they were frail or ill, either from medical comorbidities or from the cancer itself. We were really offering them palliative care, supportive care alone. For those patients who were eligible to get chemotherapy and well enough to get cisplatin, they would get that. And then patients ineligible to receive cisplatin, they can get carboplatin. So this is still a paradigm that we use in urothelial cancer, but fortunately, so much has changed, and it's changing so rapidly. We're actually waiting for the guidelines to change with us in terms of some of the recommendations. So we'll go over a few of these exciting changes. So this is currently what we call the first-line systemic therapy for advanced or metastatic disease. So you may hear this from, physicians or see this online, these lines of therapy. So if someone is being treated for metastatic urothelial cancer and they've not been treated before, then as a physician, we're thinking this is the first-line setting. It puts our communication to other colleagues and teammates on that multidisciplinary team into a context that this is the first thing a patient is getting. It also helps us communicate sometimes with insurers when we're asking for medications, because these medications have to be ordered and then approved by insurance companies, as well as our nursing staff and pharmacy staff, at different cancer centers. So that's part of our communication, meaning that this is the first treatment that somebody is getting. And of course, if there's either intolerance or the cancer progresses on first-line therapy, we move to second, third line, and on and on. So there's a lot of tools in the toolkit that we can now use in 2024, and I expect that this list is going to continue to grow quickly. So in terms of the kind of buckets that these treatments go into, or the pillars of care, I wanted to kind of simplify our toolkit for the group here today. So the first is that we can use immune checkpoint inhibitors. So those are medications that are in their own kind of class altogether. I started by talking about chemotherapy, cisplatin and gemcitabine, or carboplatin and gemcitabine chemotherapy, or accelerated MVAC. So that's still a pillar of therapy that we use. But immune checkpoint inhibitors have been approved since 2016 for urothelial cancer. And really those drugs stimulate the immune system to kind of recognize that there's cancers in our body, and then also allow the immune system to fight off those cancers, because cancer cells are derived from our own cells, which look like self. And so there's at least theory that maybe our immune system isn't fighting those cancers because those tumors look like our self, essentially. So we use these immune checkpoint inhibitors in various ways. So if patients start with platinum-based chemotherapy and have a great response, then they can continue and try and maintain that response with one of the checkpoint inhibitors called avelumab, and we call that a maintenance therapy. We can now use chemotherapy together with a drug called nivolumab, which is another immune checkpoint inhibitor, again, giving up to 6 treatments with cisplatin, gemcitabine, and nivolumab. And then if we see tumor control, continue that to hopefully continue that tumor control with nivolumab. The reason that we give these maintenance immunotherapies or continue the immunotherapy beyond chemotherapy is because in general, they're better tolerated than the chemotherapy and can be given almost in perpetuity for a longer period of time. We can give pembrolizumab alone in patients who are completely ineligible to receive chemotherapy, again, because of frailty for reasons outside of the cancer. Or we can give immunotherapies, including pembrolizumab and other immunotherapies in patients where cancer progressed beyond chemotherapy. For a limited number of patients that have a mutation or a change in their tumor in a certain pathway called the FGFR3, that stands for fibroblast growth factor 3 pathway, much more common in patients that have upper tract urothelial cancer versus bladder cancer, but it's going to be somewhere between 20 and 30% of patients. We find out if the tumor has that mutation based on a test done on the tumor tissue itself. It's called next generation sequencing. If someone has a recurrent cancer or a metastatic cancer, your oncologist is typically sending off that test as they're starting first-line therapy because it takes a couple of weeks to come back. And then they can tell you whether or not your tumor has that change or mutation. And if it does, then that's a tool in the toolkit that your physician can potentially use if needed. If your tumor does not have that mutation, then that drug is not approved for you because we worry about someone having toxicity from that medication and not necessarily benefit. This one is unique, and that's a pill. So it's an oral therapy that we can use to treat cancer. And finally, a newer category of drugs that's FDA approved for urothelial cancers. One is called enfortumab vedotin, approved in 2019. Only approval that it currently exists for that drug is in urothelial cancer. And the second is sacituzumab govitecan. So these are long names, but very good and effective drugs. That was originally FDA approved for breast cancer. And then there was a second approval in urothelial cancer. So these essentially are chemotherapy drugs, but unlike our older chemotherapy drugs like cisplatin and carboplatin chemotherapy that could cause a lot of toxicities kind of throughout the body, these chemotherapy drugs are encapsulated like in an envelope, and they are connected to an antibody. And I think of that like a magnet. So essentially, it's almost like a smart bomb of chemotherapy. It circulates in the system until it actually finds that other side of the magnet on the surface of the cancer cells. In the case of enfortumab vedotin, it's called Nectin-4. And then it essentially injects the chemotherapy directly into the cancer cell, killing the cancer cell and cells around it. So you get a heightened cancer kill from the chemotherapy with some otherwise limited toxicity in the rest of the body. Now, these drugs can certainly have side effects, but in comparison to chemotherapy, they're in general better tolerated, which is really important, and can be given to a wider variety of patients. Importantly, those that have problems with kidney function, which is a very large population of patients that we see with urothelial cancer. And then finally, more recently, and I'm going to highlight this study, enfortumab vedotin combined with pembrolizumab has become our new standard of care. So this is highlighted in this document here from the FDA, dated 12/15/23, where the FDA had granted full approval for the combination of enfortumab plus pembrolizumab. That combination had previously been approved in the spring of 2023 for patients with metastatic urothelial cancer who were unable to receive cisplatin-based chemotherapy because of kidney function issues or other medical comorbidities. But based on a large international phase 3 clinical trial that showed a substantial benefit of that combination, the FDA granted what we call full approval, meaning that any patient with urothelial cancer fitting into the category of unresectable or metastatic could be offered that combination. So to highlight what this trial looked like, and this has been presented at the European Society of Medical Oncology back in October of 2023. Publication is still pending, so we're waiting, but this is publicly available information. Patients with prior untreated urothelial cancer in multiple different sites throughout the world. It was close to 900 patients were randomized, so either to pembrolizumab plus enfortumab versus our standard chemotherapy, looking for how long it took the cancer to progress, what was the response rate, and then importantly, the improvement in overall survival. So what this graph is showing is that in patients that had the enfortumab plus the pembro, denoted EV plus P versus the chemotherapy, the response or the shrinkage rate on the cancer was higher, including complete response, meaning that on imaging, the measurable disease disappeared. It was close to 30% versus the chemotherapy, which was respectable at 44%, but still a much higher response rate. And that translates into, improvement in things like pain, as well as functional status. Overall survival was really profound. We have never in urothelial cancer seen numbers this high. So in terms of patients getting chemotherapy alone or chemotherapy followed by avelumab maintenance, which was allowed on this study, the survival was about 16 months, which is what we've seen in many other studies before, versus the patients who had enfortumab plus pembrolizumab. It was a substantial improvement in overall survival at 31 months, which is really so exciting for our patients. And then importantly, as part of my job as a medical oncologist for the last, 15 years has been deciding, whether or not a patient with metastatic urothelial cancer was well enough to get a drug called, cisplatin. Cisplatin is, has a better response rate than carboplatin does, and so really not based on biology, but based on someone's fitness, we were deciding, who was getting which kind of chemotherapy, because enfortumab and pembrolizumab are both drugs that really are not as metabolized by the kidneys and also don't have the same degree of toxicity. We can safely give those to a wider variety of patients. And so really, I think this is one of the most important things that we're seeing, is that whether or not someone could or could not have gotten cisplatin, it doesn't impact their ability to potentially have a great tumor response with this new combination, which is pretty exciting for our patients. What about cost? I pulled some of these estimates off of publicly available, websites in terms of the cost of medications. So chemotherapy, platinum chemotherapy, these are relatively cheap drugs. They've been around a long period of time, and so the cost is not in general prohibitive. But for the newer medications that have been developed, in the last decade, research into these drugs is just incredibly expensive. And so fortunately, insurers who, by the way, look to the NCCN in order to make their decisions about coverage, are covering these. And so, because it would be so hard to imagine, what that would look like. But every patient is different, every insurance policy is different, and so fortunately there are advocates like throughout, and people who work throughout cancer centers, helping patients and helping us in terms of managing these costs, and making these things affordable for patients. So in summary, really, this combination called enfortumab and pembrolizumab is now what we were considering the new frontline standard of care. NCCN Guidelines is in part based on publications, and so we anticipate when that publication is out that guidelines will change. But at the current time, we're in a very unique time in urothelial cancer. Which therapies are best to sequence if patients either can't tolerate treatment or the cancer grows through them, is always an ongoing area of research for urothelial cancer. How are we going to pair these drugs together with other treatments already on the list, or with treatments that are not yet FDA approved? We don't know. And then, of course, there's different kinds of urothelial bladder cancer. So not just urothelial cancer, but other cell types under the microscope. So there's really endless research questions and opportunities for us to think about in order to improve patient care. But certainly, I think an exciting time with lots of changes happening, and hopeful time for our patients, which is really the most important thing. So I want to thank you for your attention, and I'm going to hand things over to our wonderful colleague who we all know well through different organizations that we work with together, Mr. Rick Bangs. So thank you.
Thank you, Jeannie. It's my absolute pleasure to be here today and kind of shine a spotlight on this advanced and metastatic bladder cancer space. My name is Rick Bangs. I am a patient advocate. I'm a survivor of muscle invasive bladder cancer. I'm the proud owner of a 2006 model year neobladder. So I've had my neobladder for about 17.5 years. I do some work with the National Comprehensive Cancer Network, the NCCN, on the bladder and penile cancer panel. I also do some work for the Bladder Cancer Advocacy Network, including hosting a podcast called Bladder Cancer Matters. And I've done a fair amount of work in other spaces, particularly in the clinical trial space for the SWOG Cancer Research Network and the National Cancer Institute. And I just want to remind folks that is where your tax dollars are put to work relative to improving the lives of people with cancer. I have two goals for my presentation. One is I want to showcase some helpful resources that are available to you, and I'm going to emphasize those resources that would be appropriate for those of you who are survivors of advanced and metastatic bladder cancer or are family caregivers or partners of those people. I'm also going to provide some guidance. I'm going to talk, it's kind of a heart-to-heart, talking from one survivor to another to provide some guidance for you around navigating advanced and metastatic bladder cancer. Okay, so I want to start with the NCCN guidelines. These have been referenced previously, and just to remind people of what you probably have already picked up on, which is the guidelines are the standard of care. It's sometimes referred to as the usual care. All right, it is based on evidence. You heard Jeannie talk about the evidence needing to be published. All right, so there is some research that underlies these guidance, and then experts are pulled together, like our experts on this webinar today, to determine what the standard of care should be. Jeannie's also mentioned that these guidelines are used by insurance companies, and in this space, in particular, in bladder case in general, there have been frequent updates, which is a great thing. When I was diagnosed, that would not have been the case. I want to point out that the clinician version of the bladder cancer guidelines has a counterpart, which is a patient version that was referenced in Tanya's presentation. And so those guidelines are available to you free. All right, there is a PDF version of the patient guidelines for bladder cancer. The link is shown here. There are also some other guidelines that may be relevant as well, and those are all available as well on the NCCN site. When you download the NCCN patient guidelines, you're going to see this table of contents. So it's broken into these large groupings. The first section is a bladder cancer 101, covers kind of the entire landscape. The next session is going to relate to treatments, and it covers it by stage. You can see that starting on page 62, the treatments for the metastatic context are covered. There's a section on supportive care and other assistance, and I just want to point out that supportive care is both palliative care, which is basically working on symptoms, and hospice care, which is end of life. Those two things are very different, but there's some good guidance in there on that. There's a section on making treatment decisions, and so there's some information on informed choices and second opinions. Second opinions may be very relevant for an advanced and metastatic bladder cancer survivor. And the tip I want to provide you is that there are some very good questions. So if you're wondering, well, what questions should I ask? There are a set of questions that you can draw from here and then supplement them with additional questions. And then there is a section that tells you where the NCCN cancer centers are. You will recognize this map that was shown earlier by Tanya. So this shows where the NCCN institutions are located across the United States. I want to switch gears here and talk about the Bladder Cancer Advocacy Network, or Beacon. They do amazing work. They have a website which is, I think, second to none relative to information for bladder cancer patients and partners and caregivers and family. There is a bladder cancer basics handbook that is free. It is also available in Spanish. There is a version just for caregivers and a version for healthcare professionals. So by all means, go out to the Beacon website and download these. These are free of charge. There are tip sheets, there are webinars, there are personal stories and videos. And if you're trying to look for something, you can always use the search bar, which is the magnifying glass, and you could search, for example, for a metastatic. So by all means, go and find information that is that would answer some of the questions you're looking for. All right, when you go out to the Beacon site, one of the things that they will provide to you are some treatment options. It's also referred to as the treatment matrix. You can take that matrix and just look at locally advanced and metastatic. You can see I've circled that here, and then it'll tell you some of the treatment options that would be relevant to that particular group of bladder cancer patients. Okay, Beacon has some state resources. There's information on the elected representatives that if you were, for example, wanting to work on Bladder Cancer Awareness Day or month in your area, you would know who the elected representatives are. There are statistics on bladder cancer. There's information on sites that includes the NCCN member institutions that we have referred to previously. It also includes the NCI designated cancer centers and the VA hospitals. There's information also on local clinical trials and information on the 2004 walk to end bladder cancer and the locations that are currently available. All right, so these are some of the programs that Beacon has available, and they are incredibly helpful. So the first one is Survivor to Survivor. This is, think of it as a matching program. So if I'm looking for somebody who's like me, who's a bladder cancer survivor, I can reach out and I can get connected to that individual. And it's somebody like me, somebody who, for example, might be male and has a neobladder, or male and has had muscle invasive bladder cancer or metastatic, whatever the criteria are. Beacon will try to match you with another survivor. There is a web forum. This web forum has grown organically, and literally there are more than 50,000 members today. It is a great place to go out and ask all kinds of patient questions. You will get responses. It is used. There's people from all over the world on the website, and people tend to be really helpful. They want to help, and they usually have very, very good information. So by all means, check that out. You're welcome to, at any time, download one of our podcasts. We have, I think we're close to 60 now. There's about 50,000 downloads, so it's done pretty well. And we cover a variety of topics, but it's all focused on information for the bladder cancer community. Beacon also does, from time to time, they do patient summits. The next one is in Seattle. It's Friday and Saturday, March 8th and 9th, and the link is shown here. So that's an excellent opportunity to meet face-to-face with people locally, and folks like Jeannie and Phil will join the meeting as well. And there's also, this is relatively new, but there's also a free support line. You can see the number there. So feel free to reach out and connect with folks to get some help. For those of you who are not from the US, and I understand some of you are not, there is a group called the World Bladder Cancer Patient Coalition. And so that's comprised of advocacy groups across the world. And I will tell you it's changing rapidly. In the time that I was working on my presentation, I had to update this chart twice. I believe we are on every continent now. We have coverage on every continent except Antarctica. Who knows when that would happen, but we do have coverage on all continents. We don't have coverage in all countries, obviously, but these folks are available to you as resources. And you can look at these resources even if you're not from that country. All right, the link is shown here, and I would urge you, particularly if you're outside the US, to take a look at that. Clinical trials is something that I think is important for all patients to consider, and no matter what their diagnosis. That is my tip to you, no matter what your diagnosis, to ask about a clinical trial. You always have the option of saying no. Clinical trials are absolutely necessary to establish these new standards of care. So in order for us to get the evidence that gets published, that creates the new guidelines, we have to do clinical trials. So by all means, check out the possibility of clinical trials. Over here on the right side of the slide, you can see some options for you on finding a clinical trial. You can certainly go to the NCCN cancer centers. You can go to cancer.gov. You can go to clinicaltrials.gov. Cancer.gov may be a little more friendly to use, but it is US centric. The clinicaltrials.gov, which is a little more technically challenging, is global. So those of you who are from outside the US probably want to go there. And if you need some help, and this is a tip for you, if you need some help trying to find a trial here in the US, there is an 800 number, and you can actually talk to somebody and walk through. It's a little bit of a difficult process to find a clinical trial. So by all means, check that out. Okay. I covered the two of these items already, the clinicaltrials.gov and the cancer.gov. There are also matching services available to you, so you can seek out a matching service. And Beacon also has a dashboard. I have shown that over on the bottom right. And so you can search for clinical trials on the Beacon dashboard. So you've got some good options available to you, but by all means, talk to your doctor about the possibility and whether or not you would be eligible for a clinical trial. Okay, so this is the section in which I'm going to share insights from somebody who is a bladder cancer survivor and does a lot of work in the bladder cancer space. So these are some things that I believe would be important for you to know. The first thing is that you need to make treatment your highest priority. There's nothing more important than getting your cancer treated, particularly if you're in the advanced and metastatic context. If it hopefully is clear to you at this point that treatments are rapidly changing, that is wonderful news. They may not be changing fast enough for all of us, but nonetheless, they are rapidly changing. So it's important to make sure you're tapped into the most current treatments. That may mean you want to look into getting a second opinion, and you want to participate in a clinical trial to get that rapidly changing treatment. I want to urge people not to think that statistics always apply to you. So if you see statistics on bladder cancer, they are kind of generalized, they are historical, and so your particular mileage may vary. Your results may be different. And because the treatments available, and certainly Jeannie covered some very late breaking information, those results would look very different. So don't be disheartened by the statistics, because they may not apply to you. And they may be very different today than they would have been when they were pulled together. I think it's important to watch out for the challenges of access. So if you want to find and receive the best care, those options may vary based on who your doctor is, the clinic or institution you go to, and certainly the country you reside in. All right, so just keep that in mind. Transportation and lodging should not be overlooked. You may need to factor in your ability to get to a particular institution. Obviously, particularly challenging if you're traveling between countries. And then Jeannie talked about the cost, but and she focused, I think, on the out-of-pocket medical cost, but you have costs that are going to happen and be layered on top. Transportation and lodging is one set of costs that need to be considered. Lost wages could be another one, child, elder, senior care, et cetera. So financial questions are very valid and should be explored. I would encourage you to discuss, establish, and refresh goals of care. So what are we trying to do? Have that conversation with your family and with your medical providers. And it's not necessarily a one and done conversation. Continue to have that conversation as you go through your journey. And when it's appropriate, consider palliative care. Remember, that's about managing symptoms and hospice care. Okay, so in summary, I've hopefully provided you with some helpful resources that focus specifically on the advanced and metastatic context. And I've given you some advanced and metastatic guidance from one survivor to another. And with that, I am going to turn it back to Tanya to moderate the questions and answers.
Thank you. Thank you again to all of our presenters. Thank you, Rick, Jeannie, and Phil. The Q&A session will begin shortly. You may now submit your questions to the presenters. All right. Okay. I already see some questions have come through. So I think this one is for you, Phil. Would you elaborate on the side effects of TURBT and what is paralysis?
Yeah, when I said that word, I knew that would generate a question. I'm glad that actually came up. So TURBT is the abbreviation for transurethral resection of bladder tumor. So back in my presentation, I showed about the resection of the tumor. So that is the actual TURBT procedure. So any surgery really has side effects that are broken down in terms of anesthesia-related complications and then specific to the procedure. We focus in terms of the actual procedure of the resection of the bladder tumor. There's several potential complication risks. One is things related to perforation of bladder if the resection is too deep, bleeding after the resection if there's vascularity that's not completely cauterized, so there could be bleeding and bleeding in the urine, which may require a catheter replaced or some irrigation or potentially even going back to the operating room. And then in theory, there's always the risk of having infections, potential risk of having some symptoms like frequency, urgency, particularly when patients have a catheter. Those are typically very irritating. So things that we have medications that can help. Like we all know, not all medications have side effects, and sometimes the side effects are worse than the actual benefits of the drug. So things to think about. So I think those are all important potential complications and things that should be discussed. And the paralysis comment was, depending on where the tumors are situated, when bladder tumors are situated laterally, not to get into too much anatomy details, but there are some specific nerves that run in those areas. And sometimes if the resection is done too deep, or sometimes even the bladder is too distended, it can actually stimulate those nerves, and that can cause the bladder and the leg to actually jolt, and that potentially puts a risk of having a perforation of the bladder. So when we do know that tumors are fairly large and lateral, oftentimes the surgeon, we're going to request from our anesthesia counterparts to paralyze the patient for the procedure. That's basically a way of numbing the nerves, if you wish, so that the nerves are not stimulated potentially during the surgery and potentially risk that complication.
Great, thank you. So there is an additional question about surgeries, just about the age of those undergoing some of the procedures and how far, well, the life expectancy, I guess, after some of the surgical procedures.
Well, that's also, I'm glad that question came up. And I always tell patients, to me, age is just a number. There is biological age as much as there is numerical age. You know, I see some 50-year-olds that unfortunately look much older than their age and some 90-year-olds who look very young and very fit. So age by itself is a consideration if we're talking about treatments, but it is by no means something which will drive what treatment options we will offer to patients, whether that be localized, locally advanced, or advanced disease. And I would tell you that I've seen in my practice patients with bladder cancer, honestly, between the age of 25 to 102. That definitely is a big spectrum of age. And obviously, we want to tailor the treatment based on age as one of the components, but also based on how aggressive the tumor is and what the goals of the treatment, to what Rick brought up, goals of care are going to be.
Thank you. So Jeannie, is chemo the first line of therapy rather than surgery?
It's a great question. And again, I think it's a kind of an answer in evolution. I mean, when, Phil and I aren't that old, right? And I think when we both started in this business, it was a very dogmatic answer, right? And now that we have so many different therapies that we can use, the patients that I think are going to surgery and when they're going to surgery, that's really changing. And so that kind of speaks to this multidisciplinary approach to having your doctors really tightly communicate with each other prior to like making a decision about who's going to start, and we call these handoffs, like which clinic you're going to start in or which modality of treatment you're going to start in. But in general, if somebody has a muscle invasive bladder cancer, no evidence of lymph nodes, then their general plan is going to be upfront chemotherapy if they're eligible, and then followed by, surgery. If they're a radiation candidate, we would have that discussion with radiation as well. If someone has tumor that's moved or metastasized to pelvic lymph nodes and Phil thinks that maybe those can come out, then we might still start with chemotherapy and then decide along the way based on outcomes, to treatment, whether or not surgery would happen. But it's a very individual decision based on the patient, the tumor stage, what ultimately the local therapy is kind of being thought of, and sometimes, depending on the patient, the response to that therapy. So how's that for not really answering the question?
Well, what I'm hearing is these are very complex decisions. And I
They
was
are.
thinking about how, earlier when Phil said, you bring a family member with you, I think so, who else can we bring into the conversation to help us make these decisions? And how long do we have to make these decisions? Like, are we talking you only have a week to make the decision? Is this something that's unfolding over a few months? Like, do we have to make any decisions at that moment?
Yeah, these are great questions. Thank you so much for bringing them up. I think like part one of the question is bringing people to the clinic, and we all have family members and we want to be part of their visit, but I might be treating a patient and I can't go across state lines, to go to an appointment. So we nowadays use a lot of technology to see patients. So, as a patient, if you want a family member to be there, please, ahead of time ask, do you have a telemed option? Do you have an option where I can bring an iPad? Do you have an iPad where someone, can come from work and like be there to hear what's going on and answer questions? More and more that's happening in the office. So definitely ask for that technology. In terms of timing, sooner rather than later is when we want these decisions to be made. It's seldom that we meet a patient in the office with widespread metastatic disease where we need to start therapy, within the next couple of days. So usually have time. When you do seek a second opinion, that adds time to, to that start time, because an outside hospital is going to have to get the records, the slides from any procedures that have been done, the imaging, your labs, the time for the appointment and things like that. But, usually within a couple of weeks to at most 2 to 3 months, but really, I mean, we want those decisions made sooner. And if there's time that's going by, I always tell the patients, look, If you want to get a second opinion, we welcome that. We definitely want you to go to a place where someone's doing this for a living, but I don't want to do this in sequence. Why don't we kind of think about doing this at the same time? So as a, for instance, if someone, if I'm recommending, first line treatment and someone wants to see a physician in an outside center, I say, when's that appointment? First of all, thank you for letting me know. I think it's important to be open with your team that you're getting these opinions, because everybody at the end of the day is trying to do the best for you. And the more brains that are on board, that's great. Let them talk to each other. So I'll say, like, where are you going? When's your appointment? That's 2 weeks from now. I'm going to set up the treatment to happen 3 days later. And if we're all on the same page, then we're ready to go. If there's going to be changes, we can always make changes. But, be open with the team, I think, about those opinions. And we're often, in kind of close communication.
Rick, did you have anything to add?
Well, I just want to say you saw in her answer, and Phil vigorously nodded his head about second opinions. And to me, that's indicative of the quality of care that you should be looking for. I would be deeply concerned about a physician that is not helpful and has a negative reaction to your getting a second opinion. There could be timing considerations that need to be explored, but I think I've never talked to a patient who got a second opinion that had regrets around it. And particularly in light of this changing landscape in the metastatic and advanced space, I think it's helpful. I mean, I wouldn't drag it out, but I would encourage it, and I would make sure that you're working with a doctor that encourages you to do that as well.
Okay, thank you. So we're a little over time, and I'd like to just ask maybe 2 questions. So we do apologize, we can't get to all of your questions, but so why can't the urine be diverted to the rectum after the bladder is removed?
Well, I can take that one. So that's actually an interesting question. So that is referred to as something ureterosigmoidostomy is what that procedure was done. Is it actually was done for many, many years as a form of diversion. And I will tell you, from a surgical standpoint, it's actually fairly easy to do. Just put the ureters into the bowel. But actually what that causes is we know that mixing urine and mixing stool is a very bad combination. And those patients actually had a higher incidence of colon cancer because of the consequences of that. So a ureterosigmoidostomy is not typically a urinary diversion we would offer our patients, for that simple reason that it increases the secondary risk of other cancers. In addition to, obviously, urine and stool would result in rectal incontinence, and the quality of life, unfortunately, for patients would be pretty poor unless you have a really excellent anal tone and capacity. So those are probably the reasons I wouldn't offer that.
Thank you. So I think this is probably a common question, Jeannie, that if you receive neoadjuvant chemotherapy and then your bladder cancer recurs, do they use the same chemotherapy agents? How do they make those decisions about which agents to use next?
Yeah, it's a great question. So, if someone had preoperative chemotherapy, got say 4 cycles of accelerated MVAC chemotherapy, and within 6 weeks went to surgery, and we have that path report where I see residual muscle invasive bladder cancer and 2 positive lymph nodes, the cancer is telling me it's not responding to that treatment. So the last thing I want to do is on the postoperative setting, give more of that chemotherapy. That's a little bit different than if someone had, let's say, on imaging, some bulky lymph nodes. We do induction, chemotherapy, 4 to 6 cycles of chemotherapy. They go to surgery, complete response. And that response maybe is durable. And 3 years later, the cancer comes back. Well, I know that back then the tumor responded to chemo. So should I pull that medication again off the shelf, give that same chemotherapy? I would say whether or not those drugs are still in your toolkit is in part dependent on whether or not the chemo responded. It used to be that we would have these kind of time cutoffs, like if you haven't had chemo within the last 12 months, and we still have those cutoffs, but in part, they existed because we didn't have other drugs that were effective for urothelial cancer. You know, now this mental toolkit I'm referring to is bigger and bigger and bigger with, you know, potentially more effective drugs. So we have other options we can think about.
Okay, thank you. There was just a follow-up question about the cost,
Yeah,
right?
I'm glad
Um,
this
s-
came up.
we did say that it's kind of like this general US, just a little clarification of the pricing. I know
Sure.
you did mention where you got it, but if you could repeat it, that'd be great.
Yeah, so you know, if you were to Google these prices, you would probably come up with the same numbers. But to be clear, you know, most of the people in the US that we're seeing are going to have health insurance, going to have insurance benefits, so that the majority of our drugs are infusions. And so there may be a modest copay or no copay. It really depends on the patient. But clearly, I mean, who can afford, you know, $20,000 or $30,000 every 3 weeks? I mean, that's not really feasible. But you know, these are FDA approved drugs again on the guidelines. And so insurers are looking at this and saying, okay, this is the standard of care. Oral medications are billed a little bit differently through insurance. They're through, you know, your typical pharmacy benefits. So sometimes the copay on those can be a little bit more challenging, and patients may have to go through copay assistance programs and things like that. But for the most part, thank goodness, even with the cost, we're not dealing with prohibitive costs that are keeping patients from getting the drugs that we're recommending.
Yeah,
And go ahead.
I just want to reinforce her point about the drug companies having copay programs. This is one of the better kept secrets in cancer, and I think it's worth exploring. If finances are an obstacle, by all means explore that possibility. Your doctor is probably going to cover that with you, but in case it doesn't come up.
And that was going to be my follow-up question, Rick, is, you know, not everyone has health insurance and some people are underinsured as you mentioned, the co-pays. So where can one seek assistance in just helping to maybe complete forms or?
Yeah, I would discuss this with your doctor. They may have specific ideas. There's typically oncology social workers are available, pharmaceutical companies. Those would be the right starting points for that discussion.
Great, thank you. So we are out of time for today. I want to thank everyone for attending, and the NCCN Foundation would also like to thank our corporate supporter of this webinar. Thank you again. Thank you, Rick, Phil, and Jeannie.
You.
Thank you.